Okay, well, maybe the participants online would have heard that, but it's a basic introduction to PICO. So, how to make a good PICO or systematic review, patient intervention control outcome. So, everybody can take 1 minute to write your own PICO. Just as a, even the people online can write your own PICO for a review. Suppose you're doing imaginary systematic review for a new treatment in your own subject, whatever interests you. Write PICO, then we'll give 30 seconds, 1 minute, then Mercy will tell us in a systematic review how to, what are the current guidelines, how to make a PICO. Because if you make a good PICO, the whole review becomes easy. So the meat of systematic review is a good question. So Mercy will teach us that in 1 minute's time. We'll give 1 minute.
Good morning. Welcome to another session of CEU. Today I'll be looking at the InSynQ checklist and guide for developing and reporting the questions addressed in the systematic reviews of interventions. At first, I want to look at a new proposed evidence-based medicine pyramid. We were like, if you look at A, we're all aware of this. The ones with the lowest confidence are like case series, reports. Following that is case control studies, cohort studies, and randomized control trials, followed by systematic review and meta-analysis. I'm sure we've been listening to this throughout our post-graduation days. However, with the introduction of the grade system in the early 2000s, there have been like two problems associated with it. One problem is that can we really do systematic review and meta-analysis over all of this? And are the lines as clear as they appear to be in pyramid A? So one thing is that heterogeneity is a big problem with the systematic reviews. Either it can be clinical heterogeneity, methodological heterogeneity, or a statistical heterogeneity. So although we can try and limit this heterogeneity, we can't really eliminate this heterogeneity completely. So this can result in a little bit of uncertainty and a little bit of, like discomfort when we're trying to clump all of them together in a systematic review and meta-analysis, and the subsequent estimate of treatment. How can we, are we really sure that we can apply all of this added 1 + 1 × 2 into a clinical practice? So that is the biggest problem. So what happened was that earlier we were giving the importance solely to the type of the study design. So once grade had come into picture in the early 2000s, they have realized that it is not just the study design, but also various methodological limitations. One thing is imprecision, which is basically how small or how wide the confidence interval is. Indirectness, if the question that is being addressed in the study is the same thing as we are looking, I mean, is our patient a complete reflection of what is being answered in the question? Inconsistency. So these were the other factors that they had taken into consideration, including the study design, which actually had the only important thing earlier, like if you can see in A. So like for example, let's see meta-analysis of all the RCTs, bear in mind. In non-critically ill patients, we are looking at the effect of glycemic control in non-critically ill patients in hospitals. So this meta-analysis did not show significant difference in the mortality between the two groups. But on looking at it closely, we realized that there was no blinding and there was no allocation concealment. The crux of RCT is randomization, and so there's no blinding and there's no allocation concealment. So would this meta-analysis do much better than what an observation study is? One question. Like the second example is, we're all like aware of the benefits of doing it with hip replacement. Somebody with disabling osteoarthritis of the hip is like well established. But there are no RCTs for the same. It is just an observational study. So between the two, what would you see? The point I'm trying to make across with this analogy is that the lines between these are not really as clear as in A, but they are varying. So depending on the grade, you would either rate them one step up or rate them one step down. So that is what one change in the evidence pyramid. The second thing is the systematic review and meta-analysis over all of these things. But then it really doesn't seem to, because it depends on what are the kind of study design you're using in the meta-analysis and the systematic review. So the new proposition is that we should use the meta-analysis systematic review as a lens through which we look at other study design. So this basically comes from the fact that so we are looking at the risk of bias in the included study design, and we want to look at this, the lower part of it, as a lens through the following lens. So this is the new proposed evidence-based medicine pyramid. In the light of this, we'll proceed. So every day we keep seeing new things. So traditionally, the guidance for systematic reviews has focused only specifying questions and criteria for the review. But more and more, we've been seeing that one single review can answer more than one question, and there has been a need for PICO for each of these syntheses. So synthesis is essentially a sub part of the review. So hence there is a need for additional information to articulate the questions addressed by these syntheses. The existing guidelines do not distinguish the review PICO from the synthesis PICO, which is a sub question. There are no guidelines for the sub questions within the PICO. They have limited coverage of the elements needed for that. So what do we mean by the PICO for each synthesis? So in systematic review, the questions and criteria for including studies are defined by the review PICO. Although the PICO for each synthesis is similar, defining the questions and the studies eligible for each of them may be different. Without changing the review eligibility criteria, the synthesis can be structured to address different questions, which we will look as to how. You just have to simply group the interventions or outcomes of population differently, and you'll be able to answer multiple questions within the same review. So I'll spend a little bit of time on this particular slide. So now on the left side of the screen, you can see what the aim of the review is. So for people with osteoarthritis of the knee, what is the effect of exercise compared to no exercise on paid physical and psychosocial function and quality of life? So if I were to make, I mean, now that all of you have made PICO statements, so if I were to make a PICO for this question, this is how I will make it. P is osteoarthritis of the knee. I is exercise, any type, static, dynamic, weight bearing, non-weight bearing, low, high force, any of those. Control is no exercise, which is placebo, usual care, no intervention, waitlist. And the outcome is any health outcome. So now, if you can look at the central part of the slide. So the concept is called broad synthesis question. So here I have made small change to the PICO of the review. This I'm calling it the synthesis now. The only difference, if you can see, there's not much of a difference in the broad synthesis question. Only thing I have made it clear, I have differentiated the outcome here. Here, the first one, I had taken the outcome to be pain intensity. In the second one, I had said physical function. So it meant it is not really although a little different, but not significantly different from what the review PICO was. On the other hand, this is called a narrower synthesis questioning or grouping, where I decided to split the intervention and the outcome into multiple groups. So if you look at synthesis 1.1, I had split the intervention any weight bearing exercise, which is jogging, tai chi, whatever. And the second one is any non-weight bearing exercise. In fact, now if you look at it, now the outcome, I had changed as pain intensity, which was already here. And then under each of them, I had again divided them into pain intensity and physical function. And X, your outcome. So in fact, even this weight bearing exercise can be split into jogging, tai chi, single leg standing. So if you can see, this is the main review PICO. And under this umbrella, you can make multiple small PICO addressing each of your synthesis question. So this is the broader one, and this is a narrow one. The narrower you go in, the more, I mean, you're likely to answer more questions. But the problem with that is that you may not be able to have studies that can tell you that. You may just have one study, which is as good as not having one. Not really in review if you're looking at that. Just highlighting the difference between what a review PICO is and what a synthesis PICO is from this. So why do we need a newer checklist? So the InSynQ group had randomly selected 100 systematic reviews of public health and health intervention. And they noted that many systematic reviews use the PICO characteristic to group studies for synthesis. But reporting was incomplete. So nobody knew how they had grouped them, or how did they decide to group them essentially. And it was not really possible to identify the synthesis questions or any definition that the authors had used to decide which studies were eligible, what were the criteria they had used to include or exclude the studies. So in the background of this, the InSynQ checklist was made. It is an 11-item checklist. It was made to facilitate the development and reporting of the questions addressed in the systematic reviews of interventions. It was intended to complement, not replace the PRISMA. So we all know that the checklist that we used to make systematic reviews of PRISMA 20, swim reporting, and Cochrane's MECIR. So it was not intended to replace any of them, but taking few points in each of them to make the PICO for the sub-questions. So it was written by Subran et al. And it was funded by Cochrane, a part of it from Cochrane. So this is just showing the, so if you can remember, the PRISMA actually has 27 checklists. So out of the 27, about 7 of them have been included into the InSynQ. The swim has 9 questions, out of which they have taken 2 complete questions. And the MECIR has 75 questions, out of which they have again taken 8. So this is to highlight that it is not to replace any of these existing checklists, but only a culmination of the most important things for a subgroup. So who is this for? Authors of the reviews. Commissioners of reviews want to ensure that the plan synthesis aligns with their requirement. Editors, peer reviews, and methodologists. When do we use this checklist? First, when planning a systematic review, writing a protocol for review, and reporting a review. Items 1 to 9 should be reported in both the protocol and the review. These items cover the specification of the synthesis questions, role of groups in the synthesis. 10 and 11 apply only at review when you're writing the end part, covering requirements for reporting any changes to the synthesis questions and the reporting of results. So this is the snapshot of the website, InSynQ website. And this was made after looking, this is the article that was published in Cochrane, which is a development. Why did they decide to do, how did they come up with this? So this has, so this includes all the steps that had arrived at to come to this. How did they pick few questions from each of these checklists? If we, maybe this very simple, actually, pretty straightforward. If you, each of you can like tell one thing. So first question is specify population intervention groups to be used in the synthesis. So label each of these groups. It has to be explicit. It is not understood. Next thing is define each group. So if you are using definitions from standard references, mention the reference. In multi-component intervention, specify how these will be defined and grouped for each synthesis. If you have inactive comparators, like usual care or no intervention, mention clearly what do you mean by usual care, because usual care in one hospital may not be the same as usual care in another hospital. Specify how they will be grouped for synthesis. Describe any plans to group at multiple levels to address both and broad specific questions. One of the reasons we do grouping is if we do not have enough studies meant to answer the sub-question. We may just end up with one study which we thought may have multiple, finally we may have just one study. So you will want to group them there. Describe any contingency plan for accommodating the amount of available evidence. So in case you did not account for some variable and now you thought there are so many studies which are answering one particular question that you did not think of. So how are you going to account for it? So at the end of every question, I have like one example, if you guys can take that. So this is a review. It's a psychosocial interventions for supporting women to stop smoking in pregnancy. So let's say this is how the line said. We included any intervention based on counseling, education or feedback to women about smoking cessation during pregnancy, with information provided online or in person for any duration. I mean, you think that's okay, or if can we make any changes? 10 seconds. in the light of what I said, one thing is we have to label it, we have to make it very explicit what it is. How are we going to address if we get new information? How are we going to do at least these 4 basic points? Maybe on 10, we can say 10, 5, 3, 2, 1. 3. No. Sorry. Oh, how much do you want to score on that line? Let's say, if I say that the same thing is actually part of the review, oh, can we say 5, 3? Okay, then maybe I'll just. So ideally, we would have wanted to be in. So when I say explicit, so comparisons are based on following intervals. So here he is mentioned what counseling is. Counseling can be anything. Counseling can be 1 hour counseling. We cannot really club 2 studies which have 1 hour counseling versus 24-hour counseling, inpatient counseling versus outpatient counseling. So he is clearly mentioned counseling intervention, those which provide motivation to quit, support to increase problem solving and coping skills. He is also mentioned where the source is from. He is not made an imaginary criteria. It seems to be like this is a well-established thing and he's taken it from that. Next thing is health education intervention. Are those where women are provided information about the risks of smoking and advice to quit, but are not given further support and advice about how to do this. They're just told that this will cause a problem. Feedback intervention are those where the mother is provided the feedback with information about fetal health status. So if you can see, this includes interventions such as ultrasound monitoring, cover monitoring. If you can see, there's a stark difference between, I mean, they may be saying the same thing at the end of it, but each of those points have been clearly and explicitly described. This is question 1. Yeah.
You can't expect them to put that much information in one line. So isn't that line then?
No, so the point is that you have to have all of this. If you have time constraint, then there's a supplementary.
So it's like by itself, the line is not enough. They should have, like they have, this explanation should be there.
Yes.
What they're saying is from now on, Cochrane or any systematic review, if they say I want to compare smoking cessation 3 or 4 different methods, you have to define what the methods. First, you must say what are the methods. Counseling, health education, feedback. That is given here. But they are not defined clearly based on whose definition is counseling and what order will be taken. Because different papers may different. So now they said any of these would be called counseling. Any of this is called health education. Any of this is called feedback. Later on, when you have a paper and you're looking at this intervention, you're wondering should I include this paper or not. Once you have the definition clearly given, okay, this is included, this is not.
This also helps with reproducibility in the subsequent workup that we do. So if the space is a constraint, like you said, it's always a supplementary. The second question is specify outcome groups to be used in the synthesis. Fully specifying outcome groups allows readers to understand the specific research question, label each outcome group, define each outcome, specify the measurement method. So what is being measured? How are you measuring it? When are you measuring it? Specify the time frame of the outcome. Describe any plans to group outcomes at multiple levels, which we had discussed. Describe any contingency plan for accommodating the amount of available evidence. Let's say if you have to look at what is the benefit of antidepressants on depression, may be very different from the benefit of antidepressants on depression as measured by the Hamilton Depression Score at the end of 6 weeks of intensive CBT. So that would make a more meaningful PICO than just saying that. So that is completely describing what the outcome is. So everybody is on the same page. And you also know which study to include. If there's a study which is taking only one hour CBT, then you may not be able to clump both of them together. So primary level worker interventions for the care of people with mental disorders and distress in low and middle income countries. So this is the review, and they said we consider outcomes measured immediately post intervention as well as longer term follow-up. So longer term could mean 6 months or 6 years. Immediately could mean 1 week or 2 weeks. So we grouped outcomes into 3 sets of time points. Time 1 is short-term or immediate post-intervention, which is 0 to 1 month post-intervention. T2 is intermediate, which is 1 to 6 months, and longer term 7 to 24 months. So if an outcome was reported more than once during any of the time points, we use the latest time point within that category or the time point that correlated best with other studies compared with each outcome. So he has clearly told us at what point with regards to the time frame. Third one is give a rationale for the groups. Why are we doing this grouping? So reporting the basis helps the reader understand what options were considered, why particular decision was made, and verify that the approach aligns with the review objectives. Ultimately, it should be like we do a review, and based on whatever data we get, then we backtrack all of this. The whole idea of it is to plan everything ahead and then write a review as opposed to finding the answers and coming back to the questions. So for each PICO element, describe the basis for grouping with a rationale. So you can have theoretical rationale. So maybe you can, if you were to use drugs, maybe you can consider all the studies which included so many drugs with the common mechanism of action, or maybe existing practices. So this hospital does, these are the drugs that are given, you can use that. Or maybe a group of, based on the economy of the country. So you can use any of these methods to group the study, or you can use like interventional content as such, mode of delivery, outcome measurement, population characteristics, like we'll go through it. You can use practical aspects. If grouping is based on existing system, identify and reference the source. If you're making any changes to that, mention it. So the same thing, primary level worker interventions for care of people living with mental disorders and distress in low and middle income. So they had written that mental disorders included a common mental disorders, severe mental disorders, perinatal mental disorders, disorders specifically associated with stress, substance use, neurocognitive disorders like dementia, etc. So if we were to make it better, so he had used that it is based on the ICD-11 classification, which is not mentioned there. So this is an already well-established system and include all of these things. So what does LMIC, low middle income countries, mean? What does primary care mean? So here it appears like there was not enough space for him, and then so he's put it in a table, which is a part of the supplementary. For seasoned reviewers, this may come naturally, but for people who are just starting off, this is a good checklist to follow. Identify the role of each group in the synthesis. Specifying how groups will be used in the synthesis enables readers to understand how the synthesis is structured. So identify which of the specified groups will form the basis of comparison, and any group that will be used to stratify the study within this comparisons. So, or you can identify which of these groups will be used to explore possible causes of variation effect, like subgroup analysis and meta-regression. You should have decided what subgroups you're going to do and what are the groups that are you going to use for meta-regression. Identify which of them will be used in sensitivity analysis, essentially to see how robust the results are. If you change the method of analysis, is the result of the analysis changing or is it staying? So this is prophylactic vaccination against HPV to prevent cervical cancer and its precursors. So the B group studies by the participants' HPV status as defined by the result of an HPV DNA test at enrollment. Initially HR HPV DNA negative, initial HPV 16, 18 DNA negative, regardless of initial HPV, and by age group. So they have used these two classes to differentiate. If we were to refine it a little more, we perform separate analysis determined by the participants' HPV status as defined by these three groups. And then he has decided these will be the subgroups. Here it is not very clear if all of them will be done or what each of them, each of them will be the main thing or it will be a subgroup analysis. So he's clearly mentioned that the subgroup analysis performed if possible using age group as a stratifying variable. We distinguish, he's mentioned what younger is and middle-aged women is. And he's also mentioned that if possible, let's say he has done this after doing it, then he's not really planned for it, then he just happened to have the difference. Specify the pairwise comparisons that will be made between intervention groups. pre-specifying the comparisons whether there's an order of importance. In most of these, because we're looking at multiple interventions, each of them may not be as important as the other one. There are only two comparisons, then they're same. But let's say if I'm to do CBT versus ECT or wait and watch, for each person, one of them may be more important than the other. So you decide which one you want to do it. Maybe something like a win ratio. Specify all the comparisons to be made between intervention groups. Specify the order of importance of the comparison. State that there is no order. Specify whether co-interventions will be included in the same separate comparison. Let's say if you have 3 CBT, ECT and wait and watch. Wait and watch plus CBT versus wait and watch plus ECT. So are both of them just as important as the other one? Provide a rationale as to why you're doing this. So behavioral interventions delivered through interactive social media for health behavior change, health outcomes and health equity in the adult population. We included studies that compared interactive social media intervention to any comparator group, including non-intervention, non-interactive social media or alternate social media interventions. We can see that they seem to have taken multiple groups with no definitions to any of them. So we conducted separate comparisons based on the type of the control group. We classified them as non-interactive social media control when the control was no intervention, that is first class, or non-interactive social media control. And we classified those with included interactive social media in the control arm as having active social media controls. For these studies, we consider the most intense intervention, which is social media plus components to be the intervention. Meaning we decided that we would club 2 of these outcomes. Finally, for studies in which the same social media intervention is provided in both arms, we consider the control to be non-interactive social media. So in these studies, the outcomes of interest were related to content for this. Therefore, the content provided in the control group is similar to what the participants would have been exposed. So it is very clear as to what your primary will be, what your subgroup will be, what are all the comparisons that you're doing if one of them is more important than the other one. Ensure that the objectives align with the questions addressed in the synthesis. The ultimate aim of all of that is to see that the objectives of the review have to align with the objectives of the synthesis. You can't have one different review question and then multiple other synthesis questions. Ensure that the objectives cover the questions addressed in the synthesis in sufficient detail to match the objectives of the corresponding synthesis. Use consistent words. The same thing. You define the objectives of the review before developing a detailed PICO criteria. Like psychosocial interventions for supporting women to stop smoking in pregnancy. So this review evaluated the effect of psychosocial interventions designed to support women to stop smoking. So for that, to identify whether psychosocial interventions can support women to stop smoking. To compare the effectiveness of main psychological intervention strategies, what are the strategies that he had used? Maybe something like the SMART objectives. When we write the objectives or anything, the SMART mnemonic that we use. Specify methodological groups to be used in the synthesis. Provide readers with sufficient detail of the methodological factors. Groups and role in the synthesis allow readers to assess whether all important factors have been investigated. The main idea for doing a systematic review is to look at harm versus benefit. But the second thing also is to see how confident are we in the results that we are getting of the thing. So we will also want to look at the risk of bias, we look at the study design, outcome assessment models and all that. So that way we know that we can increase the confidence of the results that we have. So you can group them. So just like we have grouped the population and outcome, we can also group the methodological studies, like studies with low risk of bias or very low concerns, or studies with high risk of bias with major concerns. Provide the basis for grouping with a rationale. Label each methodological group. So you might want to take all RCTs as one group, or all cohorts as one group. Define each methodological group in enough detail to enable classification. Describe the role as to why you're doing this. International travel related control measures to contain the COVID-19 pandemic. So to ensure that we capture all relevant study types, we consider a broad range of empirical studies of any size that provided a quantitative measure of impact, including experimental, quasi-experimental, observational, and mathematical modeling. So, he could have said this, all of them should have been done separately, in fact. So, we considered a broad range of empirical studies of any size that provided a quantitative measurement of impact, including experimental, quasi-experimental, observational, mathematical. Given that empirical and observational studies provide a measured estimate of effect, whereas modeling studies predict such an effect, we treated these two as separate bodies of evidence in the synthesis. I would say maybe you should have separated the first two, also experimental and quasi-experimental, as one group and observational studies as one group. Here he has decided to do it as only two groups. Maybe three groups would have been better. Identify how patients, the public, and other stakeholders inform the development of questions to be addressed. We've been seeing more and more that a lot of importance is being given to patient-public involvement. So PPI in research, including development of review questions, can improve the relevance of research to patients. So you can include patients, potential patients, people who use health and social care services, or people from organizations that represent people who use these other stakeholders. So you can use it for both identifying patient important outcomes, like we may all be interested in the FEV1 or FEC, but patients may be related in quality of life if we were to do a study on a drug in COPD. And also in prioritizing the pair-wise comparison. What we think is important may not be the same as what the patient thinks is important. Describe how patients and the public and other stakeholders inform the development of the questions. Ideally using the constructs of the active. So the active framework was basically made to look at, that's another checklist that looks at PPI essentially. The active authors and consumers together impacting on evidence provides a structure for guiding and describing the stakeholders' involvement in systematic reviews. Or if there was no PPI or other stakeholders, state that. This is a snapshot of the active. So they have who was involved, patients, carers, families, other stakeholders. How were they recruited? Open is basically you send out a mail, like you could send out a broadcast to the entire hospital. And just like they sent out a mail saying, do you need to renew Grammarly or something? So you send out to everyone who wants to come can come. Close is you with this. I want David and David can call his friends. Or if you're doing a study on vaccines, maybe we will call only IMD or microbiology. And what was the mode of involvement? Whether at one point you recruit them and at one point you recruit and they don't, or for every single meeting they come. If it was a direct interaction or if they were not direct interaction. And this at what stage? Whether it is planning, writing, developing, searching, at what stage? There are about 12 stages at which people can be involved. And what was the level of involvement? Whether it is their leading, controlling, or influencing, contributing, or receiving. So this is like a summary of the active checklist. Family-centered interviews for indigenous early childhood well-being by primary healthcare services. So for that, they've said ensuring relevance to the decisions in the healthcare. The protocol received feedback from health providers and the family members who receive a family-centered intervention through the Pure Health Service about the meaning and relevance of family-centered intervention for them. We intended to conduct further pre-planned meetings using formal group methods to reach consensus. However, we were not able to do it. Face-to-face interventions for informing or educating parents about early childhood vaccination. So justification of outcome measures. So here they have split them into multiple domains. Their recent research to define and prioritize 4 outcome domains for the evaluation of vaccination communication interventions. Firstly, we developed a taxonomy of potential vaccination communication outcomes with stakeholders, including parents, healthcare providers, researchers, and policy makers. And then split them into 8 domains, which is knowledge, understanding, attitudes. Using a Delphi survey, we asked representatives from each of these stakeholders. So parents had a good role to play in this. And they had decided what is knowledgeable. So somebody who scored 50% on it, looks like it's like a knowledge attitude practice sort of thing. And what we think is adequate knowledge may not be the same as what the parents may think. If I know 5 out of 6 is good enough, but we may be thinking unless you know 8, it's not good enough knowledge about vaccination. Describe the processes used to decide which studies were eligible for each synthesis. Before undertaking any statistical synthesis, decision must be made about which studies are eligible. Describe the process to be used to decide which were eligible. The biggest problem with systematic is quite subjective. It is not a computer generated one. We all sit together and decide which one. So there is no way to completely eliminate this concept of subjectivity while picking the studies for the systematic review. But you have to report how you did it. So one way of doing it is maybe coding and tabulating. Like if I were to do a study on the psychological intervention in reducing smoking in pregnancy, maybe I can use broad classes like counseling, health intervention, feedback, so that you can include the studies in one of these 4 broad classes. Essentially, what he's saying is there is no, I mean, although there is subjective, please mention how you are being subjective about it. This is effectiveness of interventions to reduce homelessness, a systematic review and meta-analysis. So here he's got 4 dimensions. So it was a complex thing. So he divided into 4 dimensions. Was housing provided to the participants as part of the intervention? To what degree was the tenant's residence in the provided housing dependent? For example, treatment adherence, so on and so forth. So they had recreated categories so that it is easy to put them into groups. One is case management only, abstinence, contingent housing, housing voucher, residential treatment. So what they had to, these interventions were categorized according to the main component, the component the primary authors emphasized, which is one of those 4. We then organized studies according to which comparison intervention was used to any of these. The last 2 questions are only at the review stage. Label and define any groups used in the review that were not reported in the protocol. If you have at the end of the review, you have come up with new things. List any comparisons made in the review that were not there in the protocol. Example, we may not have incomplete. They may have been an incomplete intervention. We may not have really gotten enough studies to come to a meaningful conclusion. There may be some new group that had emerged that we were not able to identify while we are planning for it, or any potential effect modifier that we have found. Provide a rationale for any changes made during the review to the planned group of comparisons. Primary level worker interventions for the care of people living with mental disorders and distress. Within each group, we had planned the following: categories of healthcare workers, primary healthcare professionals, types of intervention settings. After considering the studies included in this review, we revised the comparisons. This was not as planned. So the separate analysis would be made for categories of healthcare workers and types of community interventions. Here they had put them all together. He split them there. Here healthcare and community was together, but now he split them. But they were also not able to do what they had planned. We were not able to perform other subgroup analysis to check if the intervention effect varied with different population characteristics, as the number of included studies were much small. The last question: report the results in accordance with the groups and comparisons. The reporting of the results should be consistent with the final PICO for each synthesis. Report using the same groups and comparisons, preferably in the same order as what you practice, as what you proposed. Report using the same labels. In summary, specify population intervention groups to be used. Specify outcome groups. Give a rationale for the groups. Identify the role of each of these groups. When I say identify role of each of them, basically you have to tell which of them are going to be subgroup analysis, which one are you going to look at sensitivity analysis, meta-regression, specify the pairwise comparisons that will be made, and also decide on which one is more important if it is. Ensure that the objectives of the review are aligned with the question PICO. Specify methodological groups, meaning you want to put all those with low risk of bias with very minimal certainty into one group. Identify patient-public interaction. Describe the process. Basically, mention clearly the subjectivity that was involved. Identify changes that were made at the review state to the groups or comparisons reported in the protocol. Thanks.